Hello, future nurses. This week we are going to be covering the cardiac assessment. So listening to the heart, assessing the pulses, assessing the extremities for any signs and symptoms of circulatory issue. Make sure that you take notes and that you write down if you have any questions, so that way we can clarify when you come to lab during the week. And we can address those in the first few minutes of class. All right. Okay, so before you begin your assessment, remember you always want to knock on the door to provide for privacy and respect for the patient, and also to make sure there's nobody else working with the patient. You're going to introduce yourself, let your patient know who you are. So I'm so-and-so, I'm a student nurse, I'm so-and-so, I'll be your nurse for today. And then you're going to let them know what you're there for. So I would like to do an assessment on you, if that's okay. Is this a good time? If not, you can come back a little bit later. You can say, I can come back in 15 minutes or so, okay? You will need to do an assessment on each patient that you take care of during clinical. So this is a good time to learn and practice before you go to clinical in a few weeks. So once you have introduced yourself and you're letting them know what you're there for, then you're going to, if there's a curtain around the room, you can close the curtain. Make sure that you close the door so that way it provides for privacy. With the cardiac assessment, you will be removing the gown just enough so that way you can expose the chest when listening to the lungs, and then also when you're doing any other part of the assessment. You always want to ask your patient if that's what you need to do and if they're okay with that. That's just for respect and dignity. You're going to wash your hands using hand sanitizer or washing your hands at the sink. Okay. And you're going to check the armband for name, date of birth, and allergies. All right. So, Miss Bloom, hi. How are you? She's doing good. I'm glad that you are doing well. Did you sleep well? Excellent. Well, right now I am going to do an assessment. I'm going to listen to your heart, and I'm also going to check your pulses, okay? I want to make sure that your pulses are good and strong, and that your heart is good and strong as well. I know you were having some cardiac issues in the past, so that's something that we want to make sure that there are no problems with, okay? So you're always going to be focusing on if your patient has any cardiac conditions or conditions that could affect the heart. This is where a cardiac assessment is very important. Now, the type of assessment that we're going to do today is going to be focused on the cardiac, okay? But you'll find that when you're doing a head to toe, things kind of tie in together. So just because I'm doing the pulses in the head right now doesn't mean that you have to keep it all with, oh, I'm doing the cardiac assessment. So when you're doing your head to toe, when you're assessing the eyes, the nose, the mouth, and all of that, you could be checking the pulses for the temporal and the carotid while you're up here versus waiting till you're doing the cardiac and checking them all at the same time. So, but for these purposes, we're going to do a thorough focused assessment related to the cardiac assessment. Okay, so Ms. Bloom, can you verify your name and date of birth? Okay, so Dorothy Bloom, date of birth was 5/25/51. Okay, thank you so much. And she, can you please tell me what you're allergic to? Okay, she says she's not allergic to anything, and we have verified that as well. So I have put her bed up so that way it's easier to listen to her lungs. So you would put, if they're able to tolerate it, you have to gauge and see if they're able to tolerate being in the high Fowler's position or a semi Fowler's position, okay? So At this point, I am going to raise the bed just a little bit, the height, because the patient's a little bit on the low side, the bed anyway, the bed height. So I'm going to raise it just a little bit so that way I can level it a little bit better with my height. All right, so I've done hand hygiene. Now I'm going to put on my gloves. All right, Miss Bloom. And while I'm doing this, can you tell me what day today is? Okay, today is a Monday, yes, and it's November 29th. Can you tell me the year? Yes, 2021. And again, my name is Cynthia. I'll be your nurse. Today, your doctor is Dr. Winters, and your goal today was to be able to walk two laps around the unit because we need to ambulate our patient to prevent blood clots and other complications. All right, so I'm going to put this side rail down. The first part of assessment is inspection. So what you're going to be doing is you're going to be inspecting the patient for any signs of any circulatory problem, like making sure that their neck is not distended, that their veins in the neck are not distended, that the color looks appropriate to her state, her condition. Because, for instance, if your patient, and this kind of goes with respiratory, if your patient is having trouble breathing, they're not perfusing, they're not oxygenating, they're going to be a blue color. That's called cyanosis. If they are losing blood, if they're hemorrhaging, if they're hypovolemic, because they're losing blood, they will be a pale color. That's called pallor. They'll be white. It could also be because of blood sugar, if blood sugar is low. So there could be many reasons why the patient's skin color would be abnormal. So from what I can see, my patient's skin color is according to her ethnicity, according to her state. We are going to look at the so also part of the cardiac assessment, you're going to, tie in your vital signs. So the important vital signs that relate to the cardiac system are going to be blood pressure and pulse. Okay. So when you're doing your blood pressure, as you've done your vital signs, you're checking to look at the number. So if your patient has a condition called hypertension, which is high blood pressure, you're making sure that their blood pressure is not too high. When the blood pressure gets over a certain number, it can cause problems with the heart, the lungs, the brain, the eyes, the kidneys, circulation. It pretty much affects the rest of the body completely. So we want to make sure that our patient's blood pressure stays within a certain range. Typically, the range that we want to keep the blood pressure is the top number is called the systolic. That's going to be 100 to 120. Okay, we want to keep that range. The bottom number, which is the diastolic, that's going to be from 60 to 80. Okay, so the normal blood pressure is 120 over 80. However, every single one of us has a different normal. So some people run up a little bit lower, like in the high 90s for the top number, and some people run a little bit higher, like 130s. Now, it all depends on different factors such as age, ethnicity, lifestyle, genetics. So there are many reasons why people could have high blood pressure. All right. So once you check the blood pressure, you're also going to check the pulse. So when you're doing the pulse, we're checking the pulse. We're going to do the radial pulse, okay? So that's the one by your wrist. You're going to count the beat, okay, for 1 full minute. So once you have that rate, you're also going to make note of, is the rate regular or irregular? Does it feel very fast, or does it feel pretty pretty stable with the rhythm? Okay. Oftentimes, if your patient has a high heart rate, above 100 is considered high. That's a term called tachycardia. You will feel that the beat is really fast, okay? Sometimes it's hard to count and keep up with that count because the heart is really beating too fast. So you want to make note of the rhythm. Is it regular or irregular? Is it strong, weak, bounding? So weak would be the lowest, right? Strong is what you want to find, okay? You can feel that pulse without a problem. Sometimes people will have weak or thready pulses, which could be from different reasons. Maybe it's their age, maybe it's they're losing a lot of blood, maybe they're dehydrated, maybe they're hypovolemic, many conditions, like I said. So it's going to be hard to find that pulse. Now, if their heart stops completely, aka a cardiac arrest, then they will not have a pulse. You will not feel a pulse. So whenever you have a patient that is, or you suspect cardiac arrest, always check the carotid, because the radial, it's too far away from the center of the body, from the heart. So the best place to check it is the carotid, okay? And we'll go over where that carotid is. All right, so now that we've done our inspection, we are going to, so whenever you're doing your assessment, you can have your patient sitting like this with the hands on the side, but you also want to, if you need to, you can have them lean forward just a little bit, because sometimes the heart needs to lean forward against the chest wall so that way you can hear it a little bit better. In some cases, if your patient is not able to sit up, you will just be listening to them when they're laying a little bit more flat. All right, so now that we've done the inspection part, and when you inspect, make sure that you pull the covers, okay? When you pull the covers, you can get a better view of everything, the whole picture, okay? So, all right, Miss Bloom, I'm sorry we're having to expose you. I know it's going to get a little cold, but I just want to inspect and make sure that everything looks good here. All right, so now that I've inspected the legs, no signs of swelling, no signs of discoloration, lesions, or anything like that. I'm inspecting the patient's hair distribution. That's important because that determines the circulation. So if your patient is lacking hair in their legs, that could be due to poor circulation. Unless they shave or they did laser hair removal, just ask them. If they say that, then okay, that's in the normal or the expected finding. We're also going to assess the temperature of the skin, okay? Because again, if the patient is having problems with circulation, especially in the lower extremities, the legs are going to be cold, okay? The hands are going to be cold. The body will be cold. So the warm body temperature is actually indicative of good circulation. You're also going to be assessing for sensation, okay? So you're going to be asking the patient, do they feel when you're touching them in a certain place on the feet, the hands, you're assessing that sensation. Skin integrity. Does the patient have any wounds or ulcers on their lower extremities that could be indicative of a venous or arterial disease? And those you can go over in your book. We're also going to go over capillary refill and edema, how to assess for edema. So, but at a glance, I can tell the patient does not have edema. The patient's hair distribution looks even. She hasn't had a chance to shave. And I do not see any altered skin integrity, especially at the heels. It's very important to check the heels for that, because that's a pressure point, if you remember from when we did the skin assessment. All right, so Miss Bloom, I am going to palpate your arteries, okay? So I'm just going to come here to your face, and I'm going to start at the temporal arteries. Okay, so the temporal arteries are going to be right here. So this is where you will feel your temporal pulse, okay? So you will feel that beat, okay? It should be equal bilaterally. It should be even. If at any point when you're assessing the pulses, you feel like one side is irregular or it doesn't match the same rhythm as the opposite side, then you want to palpate for a full minute. But otherwise, we're just going to palpate for a few seconds so we can get a good picture of if it's regular or not. Okay, so once you do the temporal, now we're going to assess the carotid. So the carotid is going to be on the neck, okay? So it's right below the jawline, okay? You're going to see that sternocleidomastoid. Okay, you can have your patient kind of stick their head out like this so you can see it. And it's going to be right along the side here. Or you can also locate your trachea, and it's going to be about 2 inches, 2 to 3 inches to the side, okay? When you palpate it, you can palpate it with it's best if you do 2 fingers. You can do your index and you can do your middle finger, or you can do your middle finger and your ring finger, like so. Never use your thumb to check a pulse, because then you're going to get an incorrect count. Your pulse has its own, your thumb has its own pulse. So you're always going to check with 2 fingers, and again, you're checking at the same time usually. The only one that you check one at a time is the carotids, and I will tell you why. If you palpate the carotid artery on both sides at the same time, you're going to cause your patient to faint, and that's because the carotid artery feeds blood into the brain. So essentially, when we're pressing down to palpate the pulse, you are cutting off the circulation to the brain. So you always want to palpate one at a time, okay? And the carotid is the only one that you do that with. Everything else, you're going to palpate at the same time. We're going to palpate the radial pulse. So the radial pulse, again, is going to be on the hand. So if you remember from anatomy and physiology, you've got your radius, which is on the side of your thumb, and then you've got your ulna, which is on the side of your pinky. So the radial pulse is going to be on the same side as your thumb, okay? And it's going to be just slightly slightly past the wrist, okay? Slightly past the wrist. So you're going to palpate, and sometimes you kind of have to like feel around so that way you can locate that radial pulse correctly. Okay, so we will do that with Miss Bloom. We're going to be assessing both radial arteries, radial pulses. And again, we're assessing for regularity, amplitude. Amplitude is it strong? Is it weak? Is it bounding? All right, so now that we did the radial pulse, we're going to move down to the popliteal pulse, okay? The popliteal pulse is going to be located behind the knee. This is the popliteal space back here, okay? So these are going to be harder to palpate because they're very deep. Typically, if it's very crucial to assess the pulses in the popliteal space, maybe because you're concerned about a deep vein thrombosis, a blood clot in the leg, or the patient had a procedure where they had to go in through one of the vessels in the leg called a cardiac catheterization, you're going to be concerned about the circulation in the lower extremities. So therefore, you can use what's called a doppler. So it's a little ultrasound device that can help you locate a pulse by ultrasound waves. So once I've palpated the popliteal space, or if I can't, I could just say unable to assess. Then I'm going to move down to the pedal pulses. So down here at the feet, we've got two pulses that we're going to assess. One of them is the posterior tibialis, so that's going to be located right by the ankle bone. And then the other one's going to be the dorsalis pedis, okay? So the dorsalis pedis, you'll feel it right by the toes. It's about a couple centimeters, maybe an inch or two below where the toes end. Y'all can see. And so you would palpate. And you would do that on both sides. Okay. So I will show you. So dorsalis pedis, posterior tibialis. Okay. While we're here, we can also assess the feet and check the capillary refill time. So the capillary refill time is going to tell us if the capillaries, if the blood vessels in the feet, in the lower extremities, are feeding blood into the tissues. So what you should expect to find, because what you're going to do is you're going to pinch with your nail, you're going to press down on their fingernail, and you should expect it to turn white. The nail bed will turn white because it's normally like a pink fleshy color, like mine. And you press on it with your nail, and it will turn white because it's the blood supply is being occluded. And then when you release, it should turn pink again. Okay, and it should do that in less than 2 seconds. So you're going to count 1, 2. If it takes longer, you're going to do that with each toe and each side, okay? So if you did it on the left, you're going to do it on the right as well. And you're going to do that on the hands, okay? Each finger on the hands. Because that's going to tell us how the blood is circulating in those extremities. Especially, like I said, the lower extremities, because there are many conditions that can affect circulation in that area. Now, when we're checking the pulses for characteristics, we are going to assess, like I said, the rhythm, the rate, and we like to grade the pulses. So we talked a little bit about tachycardia when the heart rate is above the normal. So the normal range or expected range of the heart rate or the pulse is 60 to 100. 60 is on the lower end, 100 is on the higher end. Anything over 100, that's considered tachycardia. Anything below 60 is considered bradycardia. So brady meaning slow, tachy meaning fast, okay? So when you are assessing your pulses, the pulses of the patient, we are looking to see, are they present? Are they strong? Are they weak? 0 to 4 is the grading scale, okay? 0 means that there is no pulse. There are no pulses. That could be maybe due to a blood clot or severe damage. No pulse is not good, okay? So if the patient does not have a pulse in the pedal pulses, dorsalis, pedis, posterior tibialis, we will verify that first with the Doppler, okay? Before we call to inform the doctor, we are going to check with the Doppler because oftentimes patients will have weak pulses or their pulses will be a little bit hard to assess or find. So make sure you verify with the Doppler first, and I will show you how we would do that. All right, so we would check the abnormal pulse or difficult to find pulse with the Doppler. So this is an example of what the Doppler would look like. Okay, so it has a button that you turn on, and then it has a volume control. Okay, so before you would use this, you need to use the ultrasound gel because it helps to transmit the sound better, the sound waves. Okay, so you would place, squeeze some of that ultrasound gel on the spot that you need to assess. Okay, turn on your ultrasound, your Doppler, and then you would place it over the area that you need to assess. Let me actually put some out so we can. On the mannequin, it might be a little hard to find it. There we go. So you should be able to hear that beating sound of the pulses. I will wipe off my patient. and I would document that the pulse was present, regular, and then all the other characteristics that we're going to cover using the Doppler. So the characteristics that I'm talking about are you're going to grade the patient on the was it when with the Doppler, was it strong, was it weak, was it regular, irregular, um, and that's before you use the Doppler before you even report or document that the patient has no pulse, that is absent. So a 0 would be absent, a 1 is considered diminished, a, a 2 is expected, that's what we want to see. A 3 is increased. So you'll feel it's a little bit stronger, a little bit more forceful. And then 4 is bounding. So with a 4, you can't miss it. It's very strong. It's very pronounced, okay? Typically with the 4, that could be because they are in fluid overload. They've got too much fluid in their body. Their heart is working overtime to circulate the blood throughout. Maybe the heart is beating too fast, and that's why it feels bounding as well. So whenever you might see that the patient is tachycardic, assess that quality as well. So again, 0 means absent, 1 is diminished or weak, thready, 2 is the expected, 3 is increased intensity, and then 4 is bounding. So these are the pulse characteristics / grading system. Okay. All right, so the next thing after we've done the pulses, the next thing that we want to assess for is edema. So when we're assessing for edema, especially in the lower extremities, okay, and I would be wearing gloves at this point, but I would be, in order to assess for edema, there's dependent edema. So edema likes to, using gravity, it likes to go down to the lower extremities, okay? So with our lower extremities, we're assessing edema. And I'm going to turn this over so you can see a little better. So when I'm palpating, I'm going to be palpating along the bony prominences, okay? So like the shin bone. Because the tissue over the bone is going to get depressed and it will stay depressed. That indicates pitting edema, okay? So if it stays depressed, then that's considered pitting edema. Sometimes you will have edema, just regular edema, that will be obviously swollen, okay? The legs get so large, like you can see the skin stretching. Sometimes there's weeping edema where there's fluid coming from the pores of the skin just because there's just so much fluid in that structure, in that body part. Okay, so whenever you're assessing the edema, you're checking for pitting, right? So the pitting is going to be dependent. We also like to grade or use a scale for describing the type of edema. So 0 is no edema, okay? 1 plus is going to be 2 millimeters depressed. That it means that when you press down, the depression, the little crater that's formed, is going to be about 2 millimeters in depth. A 2 plus is going to be even deeper. That's 4 millimeters. So it's going to leave a deeper hole when you press down on that area, okay? The next one's going to be a 3+, so that's 6 millimeters, and the 4+ is going to be 8 millimeters. The 4+ is the most severe, and it will leave a big gaping crater in the skin from that spot where you depressed your finger. And it will take longer for it to go back to its normal, you know, it'll fill back in, it'll take longer to fill back in, is what I'm trying to say. So again, edema can be due to poor circulation. It could be from diabetes, hypertension, peripheral vascular disease, heart disease, receiving too much fluid through the IV, kidney failure. Whenever there's any kidney failure, your kidneys can't filter out the fluid and the blood and all of that. So all of that fluid gets retained. Liver disease can also lead to fluid accumulation in the body, which can then lead into the legs. The other thing we wanted to talk about with what are some signs and symptoms of obstructed blood flow, of poor circulation. It's going to be pallor or mottling. So pallor is paleness. Mottling is whenever there's it's a purplish, reddish color or bluish color. Newborns look mottled because they have a hard time regulating their blood, or I'm sorry, their temperature. So when they get cold, they look mottled, and that's because of the circulation their body's trying to adjust. Sometimes the elderly can get a mottled look to their skin. Their extremities will be cold. They will have ulceration, so ulcers in the lower extremities. The capillary refill time will be greater than 2 seconds. And their fingers, when you're assessing the nails, the fingers will be irregularly shaped. They'll have a shape called clubbing. Your textbook has a really good picture on what a nail with clubbing looks like. So typically what that means is that the angle of the nail disappears, and the angle is 160 degrees. So typically your nail, when you look at it, it's going to be just sticking straight on through, okay? It just sticks on through. With the clubbing, it curves in, okay? And they call it clubbing because it looks like a club. It just curves around and it looks like a club, like a golf club. Patients with or people with COPD, they will have clubbing of the nails because the oxygenation and the circulation are kind of tied in together. So because of their condition and the poor circulation, it leads to the nail curving inward into a club shape because they're not getting enough oxygen and poor circulation per perfusion to those nails. Our nails need blood flow in order to grow and be healthy. Whenever you're assessing the nails, and this we kind of covered when we did the hair, skin, nails assessment, you also want to look at the texture of the nail bed or the actual nail, because if it's not smooth, if it has ridges or other little craters, that could indicate circulatory problems, okay? Circulatory and oxygenation problems. All right, so now we're going to get to the good stuff. We're going to listen to the heart sounds as well as listen for bruits, okay? So when you're listening for bruits, you're listening for any abnormal blood flow in the the blood vessels. So the first important one that we're assessing is the carotid, okay? When you're auscultating the carotids, you're going to auscultate one at a time, obviously, but we're auscultating using the bell. So the bell, with the bell, you can hear lower pitched sounds. The diaphragm, you're going to hear higher pitched sounds, okay? So we want to make sure that the bell is on correctly, or that our stethoscope is on the bell. And you want, when you're auscultating the carotid for bruits, you're going to instruct your patient to hold their breath for a few seconds, and you can hold your breath along with them so that way you can tell them, okay, when they can start breathing again. Because otherwise, when they breathe, that sound can be a little bit, it can muffle the sounds of the bruit, so you want to be able to hear it clearly. All right, Miss Bloom. Sometimes you can also have the patient turn to the side so that way you can hear it better. All right, Miss Bloom, let me have you hold your breath for a second. Okay. All right. There were no bruits auscultated. Bruits are going to sound like a whoosh, like a swoosh, and that's because there is some sort of restriction, some sort of blockage in that blood vessel that is causing that turbulent blood flow. So think about a hose. If a hose or a pipe, if a pipe is clogged with hair or other residue, that water that's trying to get through that pipe, it's going to be turbulent because it's not going to go through smoothly. So sometimes that's why when the water comes out of the faucet or the spout, it doesn't come out smooth. It doesn't come out like in a smooth stream. It's going to be all like weird. And that's because of, there's blockage or there's something that's occluding that pipe. So blood vessels are like pipes that carry blood to whatever structure. So anytime there's a blockage in that vessel, it can lead to bruits in the peripheral blood vessels. So in the heart, that can happen as well, where you hear the abnormal sounds or murmurs. Those are also indicative of either a blockage or hardening of the tissue that's in the valves. But know that bruits are only auscultated in the blood vessels, in the peripheral blood vessels. Murmurs are only auscultated in the heart. But they both kind of mean the same thing. They're going to sound very similar with the swoosh sound. Okay. The other thing that we would assess at this point too is the JVD, or jugular vein distension. So whenever your patient has jugular vein distension, this blood vessel, which is the jugular vein, you will be able to see it palpating, okay? You will see it throbbing, as well as you'll see the blue, like a bluish color, because it's a vein. I want you to look online and search for jugular vein distension so that way you can see some pictures of what that looks like. Jugular vein distension usually comes from fluid overload. So due to heart failure, due to receiving too much IV fluid, or they're retaining fluid due to lack of proper kidney function, liver function, or circulatory issues. Okay. All right, so now we are going to listen to the heart. Make sure that you have your stethoscope set to the diaphragm. Now, when you listen to the heart, I have it labeled here for us. you're going to need to know where to start off with, okay? So in your book, you're going to have a picture of your structures, your landmarks, okay? So if you remember the angle of Lewis or the angle of Louis when we did the respiratory, okay, you're going to have the suprasternal notch, and then the angle of Louis is that line that separates the suprasternal notch and the sternum, okay? So that's going to line up with the second intercostal space, which is where we need to be to start off with, okay? So you're going to have 5 different spots that you're going to listen to on the chest, on the heart, okay? For the heart sounds. You're going to have the aortic, sorry, the aortic, the pulmonic, Erb's point, tricuspid, and the mitral. Okay. So again, aortic, pulmonic, Erb's point, tricuspid, and the mitral should be in the midclavicular, the 5th intercostal space, midclavicular line, okay? So the aortic, what those names indicate, they are the valves in the heart. So you've got your aortic valve, pulmonic valve, tricuspid, and the mitral, okay? Or AKA bicuspid. So make sure you review those in your book before you come to class. So you're always going to start off with the aortic. So think of it as ape to man, APETM, okay? There's also another mnemonic that is used. It's called all patients take their medication. Another one is all people enjoy Time magazine, okay? Or all patients enjoy taking medication is what it is. So there will be the different types of mnemonics or different resources that you can use. This is one that I have that's very helpful, very visual. So just search online for any tool like that that can help you. So the aortic is always going to be on the right. The heart is on the left side, right? But the aortic is going to be on the right, second intercostal space. The pulmonic is always going to be on the left intercostal space, second intercostal space is going to be directly across it. So at this point, you're going to need to palpate those intercostal spaces to make sure that you are in the right spot because everyone is different. So everyone's valves are not going to be in the exact same location. That's why, like, visually, like if you just take a glance like, oh, that's where it is, it's not going to be. So that's why you have to palpate those intercostal spaces. So the left second intercostal space is the pulmonic. The third intercostal space on the left is Erb's point. The fourth intercostal space on the left is the tricuspid. And it keeps falling off. And the fifth intercostal space, midclavicular line, is the mitral valve. So with female patients, the breast is usually in the way, but you can have them lift that breast or you can lift it up for them. Make sure that when you do lift, you do it from the dorsal aspect of your hand going up and that you ask them if that's okay and that that's what you need to do. Anytime you touch your patient, you want to tell them what you're about to do because you don't want to surprise them and you don't want them to misinterpret touch. okay? Especially if it's a male nurse with a female patient. The On male patients, it's going to be very easy to locate, so there won't be a problem there. And we will have you practice on in lab on the mannequins as well, so that way you can hear the different heart sounds. All right, so with our first heart sound, we are going to auscultate, okay? When you auscultate, the patient can just be relaxed, calm. They don't need to hold their breath or anything like that. You want to make sure that you always follow this sequence, starting with the aortic, pulmonic, herbs, tricuspid, and mitral. Don't skip around, okay? Always follow that sequence. What you're going to, on your stethoscope, you're going to use both the bell, which is the shorter side, as well as the diaphragm, because when you're auscultating for murmurs or abnormal heart sounds, you're going to hear it better with the bell because of those lower pitch sounds. In some cases, you might hear extra heart sounds. They're called adventitious heart sounds, and that'll be S3, S4. Murmurs are not S3, S4. Okay, so what you should expect to hear is S1, S2. So you're going to hear like a lub-dub sound. Lub-dub, 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 lub-dub. Okay, the S1 is the lub, S2 is the dub. And what that means is S1 is I want to say it's the end of systole, the dub, or S2 is the end of diastole. You will hear S1 louder by the tricuspid and the mitral valve right here, okay? Because the way your heart is shaped, the apex or the pointy part of the heart is going to be here at the bottom. That's also where your left ventricle is. The left ventricle is the strongest muscle in the heart because it has to pump out all the blood into the rest of the circulation, to the rest of the body. At the base, so the base of the heart's going to be at the top. You're going to hear S2 louder, so at the aortic and the pulmonic valve areas. So remember, the S2 is the dub. These sounds are actually the valves opening and closing. Because they close at different times, it's going to be, that's why you hear the lub-dub, 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 okay? So I'm going to go ahead and tell my patient I'm going to start to listen. So I'm trying to hear that lub-dub, lub-dub. Okay, so that's the herbs, tricuspid, and the mitral. Another important thing for you to remember is this is also known as the point of maximal intensity. This is also where you can find your apical pulse. That's because with the left ventricle, since that's the strongest point of the body, whenever you have a patient that is taking heart medication that requires you to check their pulse, you always want to check their pulse first before you give any blood pressure medication or heart medication. You also want to check their blood pressure before you give it. But when it's a medication that affects the heart directly, such as digoxin, metoprolol, you want to be able to listen to the heart in the apical pulse, okay? So you will auscultate that apical pulse for a full minute. And that'll be more accurate than checking the radial pulse. Okay, so I'm going to cover up my patient to make sure she's comfortable. Now, whenever you start to hear anything abnormal other than the lub-dub, 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 that's where you are most likely to hear murmurs, okay? So murmurs are going to be due to the valves. So murmurs will sound like a swooshing sound, just like bruits. With murmurs, we also grade them on a scale of 1 to 6, depending on the severity of the murmur will depend on the scale. So 1 is a grade 1 murmur is hard to hear. A grade 2 is faint but heard. 3 is easy to hear. 4 is loud with a thrill. Grade 5 is very loud with a thrill. Grade 6 is loudest with a thrill. Sometimes you can hear it without the stethoscope. That's how severe it is. A thrill is actually the physical sensation that the healthcare provider will be able to palpate whenever there's that turbulent blood flow. So the best way to describe how a thrill feels over that specific structure. So for instance, if I was assessing the carotid for the bruit, you auscultate or you hear the bruit, but when I palpate, I'm palpating for the thrill. So I can feel the thrill, okay? So you hear the bruit, you feel the thrill. You hear the bruit, you feel the thrill, okay? So I would palpate and feel the thrill. That would be like when cats purr, that vibration that they make, that's exactly what the thrill feels like. You will also get that sensation when you're palpating if the patient's AV fistula or graft on their arm. If they are getting dialysis for their kidneys, they will oftentimes, when it's like long-term or chronic dialysis, they will have an AV fistula and it will be in the arm, and you can palpate, you can feel that thrill, and that indicates that there's blood flowing through it. That's an assessment piece that you will need to do if you have a patient with one of those to make sure that it's functional. If it's not functional, that's going to be a problem for the patient because that is how they're getting their kidneys, their blood cleaned out. Essentially, the dialysis machine becomes their kidney. So with murmurs, when you hear them, you're going to hear a low-pitched sound, okay? There are aortic murmurs, pulmonic murmurs, tricuspid murmurs, which would be tricuspid stenosis or tricuspid regurgitation. In the mitral valve, there's mitral regurgitation and mitral stenosis. So regurgitation is when the flaps, the valves are really weak, and so they don't. So usually when the heart opens and closes, the flaps close, right? And it allows the blood to stay in where it needs to, and then they're like little doors, okay? So when those doors don't close all the way, blood that's been oxygenated and deoxygenated, they mix. So that's not good. But with stenosis, those flaps, those doors, they're stuck. They're hardened and they're stuck. And so that blood that's trying to leave that chamber is going to flow through. And again, it's going to mix with the unoxygenated blood. And so that's where the whooshing sounds. So regurgitation comes from weak valves. So they're very floppy, okay? They flop back and forth. The stenosis, they're stiff, so they're not closing properly, okay? So they're going to stay stuck. Make sure to look in your book, review those murmurs. You will not be expected to know exactly what kind of murmur it is or where it's located, but just as long as you understand that where you might hear murmurs, in which location, okay? The other thing is with S3, S4, those are the abnormal heart sounds. Those are extra heart sounds. This you will hear when at certain times. Usually they occur in adults over the age of 30. Sometimes you will hear S3 in children and young adults under 30 years old. S3 is considered normal in this population. S4 is considered normal in children and young adults as well. S4 usually occurs just before the S1. S3 occurs just after S2. So it'll be like lub dub dub, or lub dub ta, lub dub ta. S4, it'll be more like ta lub dub, ta lub dub, ta lub dub. So again, look online for those different heart sounds so that way you can get some practice to be able to identify what those sound like, because typically you will not hear them. So in order to be able to identify when things are not normal, you want to kind of hear what those abnormals sound like. To be able to identify murmurs and the S3, S4, make sure that you use the bell of the stethoscope, okay? For high-pitched sounds, when you're listening to the lung or listening to the heart for the S1, S2, you're going to auscultate with the diaphragm, okay? The wider part. This is the diaphragm, this is the bell. All right, so now that we're done with our assessment, Miss Bloom, I'm going to document my findings. So the documentation will go something like apical pulse palpated at the 5th intercostal space midclavicular line. There were no thrills or abnormal pulsations noted. S1 and S2 heard without any murmurs or splitting. So splitting is going to be when the AV valves close at different times. It's going to sound like a gallop. Okay, that's what splitting of S1 and S2 mean. Sometimes you will also see lifts or heaves in the chest area. So whenever you're doing your inspection, you want to see, does that heart pulsate to the point where you can visibly see those pulsations, okay? So make sure that you, when you do your inspection, you're looking at that as well. The pulses were palpable. All pulses were a 2+, okay? They were strong and equal bilaterally. No irregularities were noted. No jugular vein distension was noted. The lower extremities were warm and pink with symmetric hair distribution. No edema or tenderness noted. Capillary refill was 2 seconds or less in all nail beds. Okay. No signs or no indicators of ulcers or anything like that in the lower extremities were noted. Additionally, you want to review the history for heart and peripheral vascular disease of the patient. So you will go over their health history. And if they start to develop chest pain, shortness of breath, cough, urination at night, or fatigue, you can ask them problem-focused questions to address, okay, how long has this been happening? Is it worse at this time or that time? Your book goes into more detail about those types of questions that you would need to ask. Okay, so this concludes the cardiac assessment for this week. If you have any questions, please make sure to jot them down in a notepad, and then you can bring them to class and we can go over them in the first 15 minutes or so. All right, I'll see you soon. Have a great day.